Hi, I'm Silvio Inzucchi, and it's a pleasure to be here at the top 10 topics in clinical cardiology at the Mount Sinai School of Medicine. My topic is heart-friendly glucose-lowering regimens in type 2 diabetes, and I think most of you know that there's been a lot of change in the pharmacopoeia to manage patients with type 2 diabetes, and there should be a significant interest from the cardiology community because at least two of these drug classes that are relatively new have been demonstrated to have significant cardiovascular benefits. So these are my disclosures. And the way I've structured the talk is to first review the notion of glucose lowering and its impact on cardiovascular risk, to then review the landscape of type 2 diabetes medications. This will put what comes next into context. And then we'll review two drug classes which are relatively new: the SGLT2 inhibitors and the GLP-1 receptor agonists, and their impact on cardiovascular outcomes from large cardiovascular outcome trials. And then we'll review updated treatment guidelines. First, let's review glucose lowering and CV risk reduction itself. One of the important points that we've realized over the past several decades of type 2 as well as type 1 diabetes trials is that glucose control has a significant impact on reducing microvascular complications, primarily retinopathy, but to some degree albuminuria and neuropathy as well. In contrast, however, control of blood glucose has had minimal impact on cardiovascular outcomes and including mortality. So this has been a bit of a conundrum in clinical trials. Why, when you improve the major metabolic abnormality in type 2 diabetes, aren't you able to impact the major mortality reason in patients with diabetes, i.e. cardiovascular complications? In fact, in one study, ACCORD, despite a nearly 1% difference in hemoglobin A1C between the conventional treatment and the intensive treatment group, there was actually no impact on overall cardiovascular complications, and if anything, an increase in mortality, mainly cardiovascular mortality. And this led to a lot of introspection in the diabetes community as to whether we had this right, whether controlling blood glucose to this intensive a degree would be beneficial for the cardiovascular system. Well, let's look at the landscape of type 2 diabetes medications, because glucose lowering itself doesn't have any major impact on cardiovascular complications. So perhaps individual medications with maybe off-target effects could advantage the cardiovascular system. Before we do so, let's review the pathophysiology of type 2 diabetes, because if you understand this, you can more easily understand the mechanisms of actions of the major glucose-lowering medications. Type 2 diabetes actually does not start in the pancreas, as does type 1 diabetes. It starts in peripheral tissues, namely muscle and fat, where insulin resistance is demonstrated. In the context of insulin resistance, the pancreas needs to make more insulin to conduct glucose metabolism, and therefore patients who are obese, pre-diabetic, on their way to developing type 2 diabetes may actually have hyperinsulinemia, high insulin levels, in order to keep glucose levels in the normal or near normal range. Over time, however, in a subset of these individuals, there is pancreatic exhaustion, as we say, and a gradual decrease in insulin secretory capacity. And now there's a disconnect, not enough insulin coming from the pancreas and too much insulin being demanded by these peripheral tissues. And that is obviously a recipe for hyperglycemia. The liver is also involved. It is a glucose producing organ. Hepatic glucose production maintains plasma glucose levels in between meals and overnight. That is enhanced in patients with type 2 diabetes. They are not able actually to shut off their glucose production even after meal ingestion. One can consider that the liver is also insulin resistant. The GI tract is also involved in diabetes. It is obviously the conduit through which carbohydrate calories eventually appear in the plasma. But also there is an incretin system, a neuroendocrine dialogue between the GI tract and the endocrine pancreas. These incretin hormones are released after meal ingestion, augmenting insulin secretion and suppressing glucagon secretion, which also serves to reduce hepatic glucose production. those signals are not working well in patients with type 2 diabetes. And finally, the kidney is also involved. It is a safety valve, if you will. It releases glucose at a plasma glucose concentration of 180 milligrams per deciliter, which translates directly to a similar concentration of glucose in the glomerular filtrate. The glucose threshold for excretion is actually increased in patients with type 2 diabetes to 230 to 240 milligrams per deciliter. So that safety valve is not working as well in patients with type 2 diabetes. It's a bit of a metabolic mess. Multiple abnormalities in multiple organ systems. And as we'll see later on, this is one reason why there are so many drugs to treat patients with type 2 diabetes. In fact, there are 12, but I'm here showing only 7 because these are the 7 major drug classes used in the United States. The drugs can be distinguished into 3 groups. There are those that augment insulin supply, obviously exogenous insulin and the sulfonylureas. 2 drugs that increase insulin sensitivity, so can be considered insulin sensitizers, the thiazolidinediones or glitazones, which mainly work in skeletal muscle, and metformin, which works mainly in the liver. 2 drugs that enhance the incretin system, the DPP-4 inhibitors and the GLP-1 receptor agonists, and the one that stands alone mechanistically are the SGLT2 inhibitors, which are glucoceuric agents. In 2015, we put together the ADAEASD position statement for management of hyperglycemia in patients with type 2 diabetes. The committee felt that lifestyle change was important, particularly in the obese individuals, followed soon thereafter by metformin as initial monotherapy. If glucose control was not achieved, then one of 6 other medications could be used: a sulfonylurea, a TZD, DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 agonist, or basal insulin. If dual therapy was not effective, then after several months, triple therapy would be recommended. For instance, a patient would wind up on metformin first, then perhaps a DPP-4 inhibitor, and then one of these 4 drugs could be added to the regimen. Over time, a small segment of this population may require combination injectable therapy, such as basal insulin with mealtime insulin, similar to what we'd use in type 1 diabetes, or basal insulin plus a GLP-1 receptor agonist. Here now is in chart format the individual classes, the 7 most popular classes or categories of glucose-lowering medications, some of the generic names of these classes, the mean hemoglobin A1C reduction, the mechanisms involved, and we've touched upon these already, and also the pluses and minuses to using these medications. For instance, metformin, some weight loss, no hypoglycemia, and a potential reduction in cardiovascular events. Those are the positives. On the negative side, gastrointestinal toxicity, mainly diarrhea, the predisposition to lactic acidosis in patients with advanced CKD, and B12 deficiency. And as we'll see, each of these drug classes, even the newer ones, have both positives and negatives, and these must be understood by prescribing clinicians. And we should always not forget that each of these drugs have a specific cost. Understandably, the generic formulations are now quite cost effective, whereas the branded products of the newer drug classes, specifically the DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, are quite costly. As we mentioned, 2 newer drug classes, the GLP-1 receptor agonists and the SGLT2 inhibitors, have now been demonstrated to reduce MACE, major adverse cardiovascular events. And in addition, the SGLT2 inhibitors have been demonstrated to reduce heart failure outcomes and to reduce the progression of CKD. Insulin and sulfonylureas, in terms of cardiovascular events, are likely neutral. Metformin, as I alluded to before, may have a cardiovascular benefit, although I must say that the database in support of that statement is not very robust, as we'll see later on with some of the newer agents. In the UK PDS, a sub-study involving less than 1,000 patients suggested a 39% reduction in MI and a 50% reduction in coronary deaths in those randomized to metformin over conventional diet therapy. The TZD pioglitazone was also studied in the proactive trial. And here, traditional MACE, composite of CV death, non-fatal MI, and stroke, was reduced, relative risk reduction of 16%, although this was not the primary outcome of this trial, and therefore the results could only be considered hypothesis generating. In addition, hospitalizations for heart failure were actually increased by 41% in those randomized to the TZD pioglitazone. And this relates to this drug category's tendency to increase sodium retention in the distal nephron. In fact, when you look at the number of events saved in terms of MACE, they numbered 57, which precisely the number of increased hospitalization events for heart failure, 57. Kind of emblematic of the controversy regarding the TZDs in terms of the net benefit on the cardiovascular system. Recently, our group published the IRIS study, that's the insulin resistance intervention after stroke trial. We use pioglitazone to test its effect on cardiovascular events. This was non-fatal MI and non-fatal stroke in a group of more than almost 4,000 patients who had recent stroke or TIA. Importantly, these were not patients with diabetes, but they had insulin resistance. Most of them actually had pre-diabetes. And you can see that pioglitazone actually reduced the primary outcome by 24%. So I'm not sure the story is completely closed on pioglitazone. I personally believe that it does have an anti-atherosclerotic effect, but one needs to be cautious in terms of dosing and patient selection because of the heart failure risk. Although I will point out that in IRIS, we excluded patients with heart failure, allowed for dose adjustments, and we did not see any statistical increase in heart failure events. So for metformin, we can say that there is still a question mark, potentially a benefit, not a robust data set. And for the TZDs, I would say plus minus. The next series of medications that were studied in terms of a large cardiovascular outcome portfolio were the DPP-4 inhibitors, and they were found to be neutral. And as we'll see, the GLP-1 receptor agonists and the SGLT2 inhibitors are both demonstrated to be positive. This new information from the three last categories, DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, comes to us because of the FDA guidance to industry that was released in 2008, more than 12 years ago. Here, the agency mandated that new glucose-lowering formulations coming to the US market had to document, at the very least, cardiovascular safety. And this emanated from several years of controversy regarding the link between glucose lowering itself and cardiovascular endpoints. These were the series of trials that emanated from the FDA guidance, again, at top 5 trials regarding DPP-4 inhibitors, in the middle 6 trials regarding GLP-1 receptor agonists, and at the bottom 5 trials regarding the SGLT2 inhibitors. As mentioned, the DPP-4 inhibitors were essentially neutral for MACE. So these drugs were felt to be safe, but not necessarily efficacious to reduce cardiovascular outcomes, although it's important to point out that controlling hemoglobin A1C has already been demonstrated to reduce microvascular outcomes. So there was some purpose to glucose lowering, but again, no additional advantage for the cardiovascular system. The next series of trials were from the SGLT2 inhibitor field, and let's review these in some detail. SGLT2 is a transporter in the proximal nephron that is responsible for glucose reabsorption. If the glucose concentration in the plasma, and therefore the glomerular filtrate, is less than 180 milligrams per deciliter, and these transporters are not overwhelmed, then there is minimal glucose excretion. However, if we block SGLT2 with a pharmacological inhibitor, we excrete 70 to 80 grams of glucose per day, which translates to 300 calorie loss per day. And just like I mentioned before with metformin, with the SGLT2 inhibitors, there are positives and minuses. So glucose lowering, low hypoglycemia, modest reductions in weight, about 2 kilos, modest reductions in blood pressure, about 4/2 millimeters of mercury, and a few additional benefits as well. Patients did have an increase in genital mycotic infections, mainly related to glucose in the urine. Initially, a question of increased UTIs, although that has not panned out in larger trials. Increased risk of diabetic ketoacidosis, mainly in very insulin deficient patients, but patients would perceive increased urination, and they could have a tendency for dehydration, a small reversible decrease in GFR, and a few other risks as well. And then all of these potential negatives were put into context when we published the EMPA-REG outcome trial in late 2015. And the most striking result from EMPA-REG, which tested the SGLT2 inhibitor empagliflozin versus placebo, a 38% reduction in cardiovascular mortality. When we look at additional SGLT2 inhibitor trials, such as the CANVAS program with canagliflozin and the DECLARE trial with dapagliflozin, one can see that there is an overall benefit, a 14% reduction in MACE from these trials in those patients with established ASCVD. If only multiple risk factors were present, the effect of these drugs were essentially neutral. When one looks at heart failure hospitalization, there was a striking reduction across these trials in those both with and without ASCVD. So the drug appeared to reduce heart failure hospitalizations even in those patients with multiple risk factors. When looked at differently, this is now dichotomizing patients based on the presence or absence of heart failure at baseline. You can see that there are additional benefits throughout the spectrum of heart failure risk. So very clearly, the SGLT2 inhibitors not only reduce MACE, but also prevent heart failure hospitalization. You can see that across the trials, the risk reduction is somewhere in the 30 to 35% range. This is a striking result because there had never been any glucose lowering medication previously to reduce heart failure hospitalizations. In fact, as mentioned, the TZDs, if anything, increased heart failure hospitalizations. This led to significant interest from the cardiology community regarding the possibility that an SGLT2 inhibitor could be a heart failure medication. And this is the DAPA-HF trial that was published last year. This is a HFrEF study, so heart failure with reduced ejection fraction. Interestingly, we recruited patients both with and without diabetes into DAPA-HF. 26% relative risk reduction in the primary outcome of worsening heart failure or cardiovascular death. And importantly, when we looked at patients both with or without diabetes, there was no heterogeneity. So clearly, this medication helps patients with heart failure, even if they do not have diabetes. Just recently, empagliflozin was also studied in the EMPEROR-reduced trial. This is another HFrEF trial, and you can see that the point estimate being almost identical to DAPA-HF. And again, in EMPEROR-reduced, no significant heterogeneity based on the presence of diabetes. There are two HFpEF trials underway, EMPEROR-preserved and DELIVER, using empagliflozin and dapagliflozin, and will have results in 2021. Let's move now to the second drug category, the GLP-1 receptor agonists. This is regarding the incretin system. There are several signals that emanate from the GI tract under the stimulation of food to essentially turbocharge the pancreas to produce more insulin and also less glucagon. The hormonal signals involve two incretin hormones, GLP-1 and GIP. Just a reminder that the enzyme DPP-4 metabolizes incretin hormones, and the gliptin drugs, the DPP-4 inhibitors, sort of like a double negative, will inhibit that enzyme, allowing for increases in circulating concentrations of the incretin hormones. But the GLP-1 receptor agonists are pharmacological activators of GLP-1 receptors, and the relative concentrations are much higher with GLP-1s than with DPP-4 inhibitors. As mentioned, the the flozins or the SGLT2 inhibitors were mostly positive. The most recent result from ertugliflozin, called the VERTIS-CV trial, was actually neutral for MACE, although they were able to demonstrate a heart failure benefit. And the first of the GLP-1 receptor agonist trials, ALIXA, was actually neutral, although that was an acute coronary syndrome population. It may not have been the best population to demonstrate a benefit from a GLP-1 receptor agonist. And I'll review some of the next 5 GLP-1 receptor agonist trials in the subsequent slides. It all started with LEADER, looking at the daily GLP-1 receptor agonist liraglutide. And here, very similar to the overall MACE effect of 14% with the SGLT2 inhibitors, most of these patients had established CVD. I think it was about 80%, and the hazard ratio was 0.87, so a 13% relative risk reduction in MACE, and they also demonstrated reduction in cardiovascular mortality. This was a meta-analysis published by Marsico earlier this year. 3-point MACE across 6 or 7 trials was down by 12%, and of borderline statistical significance, a reduction in cardiovascular death to the same degree by about 12%. Now, there may be a bit more heterogeneity between these trials. LEADER, SUSTAIN-6 with liraglutide and semaglutide were both positive. Albiglutide was actually quite positive, but that drug is no longer marketed. And REWIND with dulaglutide was positive, and I put that in a bit of yellow highlight to remind me to tell you that REWIND was mainly a primary prevention trial. The majority of the patients in REWIND who were randomized to dulaglutide or placebo did not have established CVD, although they did have risk factors. So one could say that REWIND suggests that in contrast to the other studies, which mainly had secondary prevention in mind, these GLP-1 receptor agonists may actually prevent the new development of coronary artery disease or cardiovascular disease in general. As mentioned, ALIXA was neutral, as was long-acting exenatide in EXCEL, but the majority of these trials have been demonstrated to be positive. And to wind up, let's talk about the impact of these trials on treatment guidelines from both the diabetes as well as the cardiovascular communities. These, as you recall, were the guidelines from ADA and EASD that I showed you before from 2015. Notably, this was before any of these large CV outcome trials were published. So there was nothing in this set of guidelines guiding us regarding the impact of these medications on the cardiovascular system. We might say this was a very glucose-centric guideline. It was simply driven by hemoglobin A1C. And I might say that these were indeed, even though it was only 5 years ago, these were indeed the dark ages of diabetes therapy, because we were in the dark in terms of the impact of these medications for the most part on the cardiovascular system. So the renaissance, if you will, for diabetes treatment from, again, the 2 main organizations in the world, the American Diabetes Association and its sister organization from Europe, the European Association for the Study of Diabetes, the EASD, came up with these new sets of guidelines. This one published in 2019. It's a bit overwhelming, but for a point of discussion today, I just wanted to focus on the left-hand side of this slide. After metformin monotherapy, then the question that is asked, or should be asked by the clinician, the prescribing clinician, is whether the patient has or is at high risk for ASCVD, CKD, or heart failure. Well, why is that? Well, let's blow it up. If ASCVD predominates, then preferably a GLP-1 receptor agonist or an SGLT2 inhibitor could be used in addition to metformin, based on the effect of these drugs on MACE. If heart failure predominates, or CKD, hold the CKD notion just for a second, because I did not review this specific data for you, but let's remember that the heart failure effect of the SGLT2 inhibitors are significant, and therefore if heart failure predominates, then the preference would be for an SGLT2 inhibitor. There's also a effect of the SGLT2 inhibitors on the progression of CKD, topic for another lecture perhaps. But if CKD is present, as long as there are substantial GFR still present where the drugs can be used, they shouldn't be prescribed, at least to date, under 30 milliliters per minute. But in mild to moderate CKD, then an SGLT2 inhibitor would be the preferred agent. Importantly, the most recent tweak to the guidelines mentioned that these choices of agents should be considered independently of baseline A1C or the A1C target. So this is a radical departure for the diabetes community. They're saying that after metformin, even if you're under good glucose control, consider adding these medications simply for their cardiovascular or kidney benefits, much less glucocentric than in the past. Now, cardiologists see diabetes patients with ASCVD actually much more commonly than diabetologists. There are many more of you than us. And therefore, the cardiologists have been interested in developing their own guidelines for the management of type 2 diabetes. And I think this is actually welcome. These are from the ESC. And the bottom line is that if diabetes and ASCVD are present, then patients should be offered an SGLT2 or a GLP-1 agonist even before metformin. So this is pushing the envelope a little bit, suggesting that foundation therapy may no longer simply be metformin. And obviously, if they're already on metformin, then you would add one of these drugs. On the latest iteration of the diabetes guidelines, they do mention patients at high risk that this could also be considered, that you don't need necessarily to have established CVD. The ESC takes us a step further, denoting patients either at high risk or very high risk. And as you can see here, this incorporates many of our patients with type 2 diabetes. Well, allow me to conclude. Correcting the major metabolic defect in type 2 diabetes, namely hyperglycemia, has had very little impact on its major complication, cardiovascular disease. As regarding older drugs like metformin, SUs, insulin, and the TZDs, these drugs have either been demonstrated to be neutral or have controversies regarding the risk to benefit ratio. Given these and related controversies, in 2008, regulatory agencies began to mandate large cardiovascular outcome trials for new diabetes medications. The first of these trials with the DPP-4 inhibitors proved neutral, safe but not effective to reduce cardiovascular events. In contrast, two newer drug classes, the SGLT2 inhibitors and the GLP-1 receptor agonists, have now been clearly demonstrated to reduce major adverse cardiovascular events. The SGLT2 inhibitors, in addition, appear to improve heart failure outcomes, even in the absence of diabetes in patients with HFrEF. So these positive trials over just the past 4 or 5 years are leading to a rapid evolution in our approach to managing type 2 diabetes and should be of enormous interest to the cardiovascular community. Thank you so much for your attention.